Welcome to this Monday episode of the Compliance Guy. You may be wondering, how come there's only 4 people? Well, it's because it's my lucky day. No Scott, no Paul, just very intelligent ladies. So today I'm joined by Stephanie Howard, Christine Hall, Terry Fletcher. We have a great episode for y'all. Really excited about this. But before I do, I just want to quickly share with y'all some stuff real quick. Let me put this on. So we are here for the fall. The winter is right around the corner. You may be wondering what this symbol is on the beanie and on this sweatshirt that I'm wearing. And this is for Mason merchandise. This is my very, very good friend, Keith Mason. He was a professional rugby player for 14 seasons at the highest level. He is an actor. They're talking about him maybe for the new 007 movie. But most importantly, he's a philanthropist. And 100% of the proceeds from this merchandise goes to a charity that both he and I feel very passionate about. It's the Tafida Rakib Foundation, which is building hospitals for children with brain injuries. And I'm going to post some information throughout the podcast today where you can get this merchandise, where you can check out the Tafida Rakib Foundation and learn all about the wonderful things that they're doing. All right. With that said, I want to welcome the ladies to the discussion today. I'm going to remove this beanie from my head, and Lord knows what's going to happen when I do. But Terry, I'm going to let you kick off the very first topic of today.
Okay. Well, one of the things that has been kind of going on, I think, with all of us as consultants and people out there that are giving advice and are contracted to give advice is that we get a lot of feedback, we get a lot of questions, we get a lot of emails, and people are saying, hey, how come this isn't getting paid? When at some point we've already given some kind of an educational webinar on it and we've invited people to that, or we have it on our website, or we've talked about it on a podcast. But I noticed that a lot of people are more interested in billing for something and hoping it gets paid instead of expecting it to get paid. And then when it does it, they write it off. And I just know, as not just a private auditor for practices, but as a payer auditor, they look at that. If you're doing that, then that's actually considered unfair practices, and on some level, it can be considered a fraudulent claim because you're billing for something. Bundled means B status. It means you're already getting paid for it in the major procedure that you're doing. And if it is a non-covered service, it's supposed to be something that the patient has to be informed about, that that's not insurance payable, and they have to have some kind of financial agreement. And obviously, the No Surprise Act says that it can't. You also have to have a good faith estimate within $400 that they understand what they'll be responsible for. But you can't just bill for something and then write it off. You can't do that because, again, that means that you're trying to see what sticks to the wall, and that's just not okay. The second thing, and then I'm going to send it over to the ladies, is that there's also different, I don't want to call them lists, but different published guidance. Let's talk about that. Published guidance out there where you can find out if something's billable, like an assistant surgeon, or which provider, like a nurse practitioner, PA, can bill for certain services, and RNs are not nurse practitioners. Or when we talk about injections, there's actually a list or published guidance out there for Medicare that says likely self-administered, but the patient says, I don't want to inject myself. I'm bringing in my own medicine, and you're trying to bill for an injection. You can't do that. You can't bill for it. Listen to what we're saying. Can you charge the patient to do it? Yes, as long as they know there's an out-of-pocket charge. And then the last thing is, a lot of practices, and I can't believe we're saying this in 2023, still aren't verifying patients' insurance benefits or coverages. You'd rather just bill it, get a denial, and say, oh, I guess that's not covered. Either let's write it off or try to charge the patient. And again, that's not only is it not best practices, some payers don't allow it in their contract, and Medicare definitely has a problem with that. So, Christine, let me send it over to you. I know you're dealing with some things there. Let's start there.
Well, thanks, Terry. And, one of the things that I tell practices that I work with is if you're going to provide a service, the least we could do is run it through the compliance team. Let's see if there's any policies out there. Let's see if we understand the CPT code, the indicator statuses. Like you're saying, it's bundled in. It always be bundled in. I think a little bit of due diligence in the front end will pay off in the long run. You're not fighting with insurance companies arbitrarily. You're not writing balances off that could be collected under different circumstances. And I think you hit it on the head, Terry, when you said there are a lot of things out there that are not medically necessary for the insurance company to pay for. Not that it's not, if a patient doesn't want to self inject, that's totally up to them. But does it mean that the insurance company is responsible to pay for that? Or is that a fee that we charge that patient there? So I see that a lot with, um, providers that are seeing somebody preoperatively, and well, the hospital requires us to have XYZ testing done before the patient can have this surgery. Is that a hospital requirement? Is that a hospital policy? Or is that really what's medically necessary for the insurance company to pay for? There's a fine line there on a lot of those things. So I think a tiny bit of prevention, due diligence before we start doing these procedures, we'll see it on the other end.
And let me just kind of circle back around to the bundling. Bundling, the word bundling is actually a Medicare word. Okay, a lot of the private payers do use that, but I just want to explain it just a little bit further. Bundling means that you are billing a primary service, and extra services that you're trying to get paid for are already part of the primary service. So, trying to carve out extra money or extra reimbursement for something that Medicare feels you're already getting paid for in the primary service, it has a zero status on it. I mean, you can't bill it. And I think some people think that bundling just means that this payer says that it's not something they'll pay for. No, they think you already got paid for it. So think about that. If you try to bill for something that's in a bundled status, you're double dipping. You're trying to get paid for something that, again, Medicare says you can't. And I've started seeing that says you've already been paid for it. And I've started seeing some of the private payers that have used the same term, because some people say, oh, we follow Medicare guidelines. And they're saying you're already being paid. And you've probably seen the denial code on your EOB where it says this is bundled service or this is inclusive of the major service. Now, it's not always the case that the payer is correct on the EOB, but again, and I know Sean and I are going to be talking about this tomorrow. You have to do your due diligence and know what those services are. And if you don't, and just trying to bill for it, hoping you get paid, instead of expecting to get paid because it's a clean claim, you're treading down a very dangerous path of really looking at um, you know, uh, reimbursement from the payer when you don't expect it from the patient. And I see a lot of practices and coders and billers saying, well, just put a 59 modifier on it, it'll get paid. And as I face plant, it's just like, no, that's not what that's for. So, Stephanie, I'll send it over to you.
Yeah. So I think with this conversation, we have to pause and think about a particular thought process here. And with both of you, I've heard you say this. I see it in the comments where there's references to billing based on what you think you're going to be lucky enough to be paid for, right? But what people don't realize is that we live in the environment of a pay and chase industry. So they will pay those claims if they don't have specific algorithms in their system to deny that out. Do they load in NCCI edits into their claim scrubbing? I would think that they would, but no, not every time. So when you're billing these things out and you either know or did not take the time to check and see if those are bundled, that still is on you. So one of the things that, Sean and I have been through, and sometimes it deals with bundling, sometimes it doesn't deal with bundling. Even if we look to like the dreaded specialty of lab billing, with all of those services. I know, Sean, I'm not going down that rabbit hole because it's painful, but every single time we work with those clients, their claims are always paid and they're coming back afterwards to collect the money and the fees and the penalties and everything on top of it. So I find it very interesting, even just last week, within the last month, multiple times this year. I work with clients who do not have any resource for NCCI edits. And whether they have actual coding staff or whether they have billing staff, they ask me a question about, why did you say this on the audit? Why do you say that those things cannot be billed together? And then we have to have the conversation about encoder systems and software. So, it's not something where you get a free pass just because it made it through the insurance system. And one of the other things that I'm sure most, if not all of us on this podcast are aware of, we're dealing with most of the time that 6-year look back period. And a lot of my clients don't even realize that it's that far back. So there's a lot of things that you can have in place to protect yourself. And this is not a method of gaining that extra money as you continue to lose, reimbursement and fee cuts and different things like that.
Well, one thing I
So
think was really funny, Stephanie, that I was thinking about as you and Christine were talking. Do you ever get clients that say, and I know Sean, you and I have talked about this, that say, well, you don't have anything in writing that says I can't do it. And so some things are kind of common sense. I mean, perfect example. I talk telehealth a lot. I know Christine does too. And in the 99441 to 443 audio only codes, it says it can't be from a visit that was related 7 days before, and it can't be for an anticipated first available appointment or one within 24 hours. And sure enough, I'll see a phone call code, and then I'll see a visit where the patient came in or had an audio and video visit, and within a time period, and same diagnosis, nothing's changed. And I'm like, well, and then they'll take back the phone call money. And the practice is like, okay, why are we seeing these denials? I'm like, you're not seeing denials, you're seeing takebacks from what is common sense. And I know I hate to use that phrase because everybody's like, well, that's mean. I'm not trying to be mean. I'm saying read your codes. What's in that is part of that code. And again, it's double dipping. And Sean, I'll throw it to you. You and I see that so much.
yeah, there's God, so much great information. And so a couple things that I want to talk about very quickly. Modifiers, right? So I'm always talking about the critical importance of running your utilization reports and understanding what patterns may be detectable, right? Understanding who or how many of your providers absolutely have aberrants in their coding patterns. And while everybody wants to focus on CPT codes and diagnosis codes, you cannot ignore your modifiers. Modifiers are critical, right? Because not only do they provide information, right? You have informational modifiers, but you also have modifiers that manipulate the amount of money that you actually get reimbursed. The 58, the 59, your 76, your 77, your 25 modifier. So when you're running your utilization reports, make sure you run your utilization reports for your modifiers as well to ensure that you understand the frequency and whether or not these modifiers are being applied excessively. The second thing that I want to talk about, and then I want to get Stephanie's take on this. I want to talk about something that I don't know if it was Christine or Terry who brought it up just a moment ago, where we're talking about the pay and chase model. Okay. And what I always try to explain to my clients is that the easy part of coding and billing is getting paid for the claim, right? The hard part is hanging on to that money. Now, medical necessity, appropriateness, reasonableness. I have a lot of folks, and Terry, I think it was you or Christine who was just talking about this, where they're like, well, there's nothing that says I can't bill for the service. Well, folks, there actually is a section for Medicare, and it's in the Medicare Program Integrity Manual. It's Chapter 3, and it's Section 3.6.2.2, and it's referred to as the reasonable and necessary criteria. Now, CMS issues national coverage determinations, right? And those NCDs specify whether certain items, services, or procedures, or even technologies, to your point, Terry, about telehealth services, are reasonable and necessary. And if you're wondering where this comes from, it comes from Section 1862A1A of the Social Security Act. And what it specifically says is, in the absence of an NCD, Medicare contractors are responsible for determining whether services are reasonable and necessary. And for determining whether services are reasonable and necessary. And if no local coverage determination exists for a particular item or service, well, then it's up to the MAC, or it's up to the CERT, or to a recovery audit contractor, or even a UPIC to consider whether or not an item or service is reasonable and necessary for the purposes of either remuneration or being able to hold on to that. And there's several aspects of this, but there's one last thing that I will leave you with, because I always have a lot of folks that tell me, well, why should I be responsible? Well, because there's something called limitation of liability determinations. And what it basically means is, listen, you should have known because the information exists. You just didn't take the time to do your diligence to go and search for that information. And for those of you who are providers and you don't like the fact that your internal auditors or your compliance team or your coders or your billers are telling you no, so you go around them hoping to find a consultant who's willing to tell you yes, stop doing that. Okay, Stephanie, go ahead.
Yeah, so one of the things I wanted to point out, and for me personally, I found more of this when we have been working on the law side and we're having to look for defense for our clients. If you dig into the participating provider manuals with each of the individual commercial payers that you're contracted with, you'll actually see language in there that states that they follow CMS and CCI. And usually that's the least of the information you'll see at a base level. Sometimes there will be other references to CMS policy as well. But I find a lot of the times when I have these conversations with clients, and it really makes me cringe, they'll say, well, that's what we do for Medicare. Or I only want to audit Medicare patients because commercial payers is kind of like this free for all. We get to do whatever we want. So it's important to first show a connection through the participating manual if you've not seen that, if your providers have not seen that. One of the other things, and this is not something I have in writing, but I just know from the time that I've spent training auditors from payers, and at NAMUS we do train different payers as well. It's not like it's just one particular one. They have told me that internally that they do follow CMS even when it's not written. So, I know for us here on our side, when we're auditing for educational purposes, CMS is basically our Bible. That's what we need to follow to make sure everything's on track. And that's just due to the mere fact that they're the ones who are publishing the majority of the guidance. Okay, Christine, did you have something to add to that?
Well, I think we were talking a lot about just because a diagnosis can be paid, does it support the medical necessity, like Sean was saying? We have to remember medically necessary to diagnose and treat a disease, an injury, an illness, or a malformed body member. So I battle a lot with the chest x-ray for annual chest x-rays. Well, what are you treating? Hypertension. Okay, can you give me some explanation? Because I'm not a clinician, but I understand hypertension to be something that the heart is pumping blood, and we get those ranges systolically and diastolically about the rate of pumping. How does a chest x-ray help you treat hypertension? Now, I know that there's other things that contribute to hypertension and other things that they can find on the chest x-ray, and that's usually the reason that I get. But recently there was an LCD that actually said that regular hypertension isn't necessarily an indicator for a chest x-ray. So they would have to provide that additional information to get it paid, even though hypertension is not one of those diagnoses that is excluded from medical necessity. So again, you have to explain why Just because you can get paid for it, why are you doing it to treat that condition, not just to get the dollars?
Well, and the other thing I see too is that when I'm trying to explain to somebody that I don't have black and white, that you can or can't do this right in front of me. Now I'm having to explain, well, why did you come up with that? So one of the things that comes up a lot is that, and this kind of ties into what we're all talking about and referencing back to Sean, just because a patient wants it, just because a doctor says, I want an extra test, isn't the payer definition or even Medicare's definition, the Social Security Act's definition of what is medically necessary. And one of the things that kind of struck me as a way to explain this is the fact that in our new E&M guidelines, one of the things that's a big, big deal is that you can't get credit under problems addressed unless you are addressing them by either treatment, by either workup, history, exam. You're showing that your medical decision is the one that's referring a patient out for rheumatology because they've got chronic pain, or you're sending them out for an orthopedic referral because you feel like they've messed up their shoulder. But just because the patient wants it because it's something they saw on TV doesn't mean that they get it or that it's medically necessary. Or if a doctor says, I need an extra, or go ahead and do EKGs on every established patient that comes in, I'm like, why? And they're just like, well, because I'm a cardiologist. Oh my gosh. Just because, that to me, that's like saying, I stayed at a Holiday Inn Express last night. Come on, people. Yeah. And, we have different things where people now are trying to get diabetes treatment and use that for weight loss drugs, which is sucking the life out of diabetes patients and what they can get, and it's just, it makes me nervous because we see these, and I think social media some days sucks. It's really putting things out there and only, 30% is accurate. And people are finding these things, or they're going on Dr. Google saying, oh, if I do this, I'm going to be in perfect health. They go back to their physician saying, I want this. The doctor writes them a script, sends a referral, does something without a workup. So to me, think about that in the new guidelines. AMA obviously did. And they said, and so did Medicare, since they also approved of those guidelines. If you're not the one addressing it, if you're not the one figuring out if it's needed, medically indicated under your medical decision making, then maybe it isn't. You're not getting credit for it in how you level your visit. So why should you get credit for it, as far as a referred test or getting paid for it? Because God, heaven forbid what Christine was saying, you own the company now, so it's your side hustle. But Sean, I'll throw it back to you because I'm sure you've got some regulatory issues with that too.
Yeah. Well, listen, to your point about the diabetic treatment, listen, stop listening to these celebrities. They're not clinicians. They're not medical doctors. When somebody comes up to you and they say, oh, I just took Ozempic and I lost 54 pounds. Well, what else did you lose? Okay. What else possibly could be the long-term effect of taking a medication for which you have no clinical indication, but God forbid down the road, now you need it? Your body's going to build a resistance or a tolerance to it. Stop listening to the freaking Kardashians. Okay. Number two, I think Ginger Avery put something up that is really good. And I just want to talk about it because a lot of folks depend on outsourced coding, right? And you're so right on this, Ginger. They think that it's out of sight, out of mind. Okay? And the fact is, these coding companies are an extension of your organization. You don't get to turn a blind eye or a deaf ear, okay? Remember, when we're talking about the healthcare fraud statute, we're talking about intent, okay? It's an intent-based statute that says if you intend to create a scheme or an artifice or to defraud the federal government out of monies, they're going to come after you. Well, sending it to a third-party billing company or coding company that you have not vetted, and I want to be very clear because I just came back from speaking with Ron Chapman and Eric Rubenstein on a panel at the American Medical Billing Association. Billing companies can be wonderful. They can help you navigate the muddy waters of billing for services. They can help you with credentialing. They can help you with your coding if that's what you hire them for. But you got to vet them. You got to make sure that they have the requisite skills in your specialty to do the work that you want. But some folks look at it and they say, well, Sean, you know, I gave it to the coding company. They have all certified coders. Well, there's something else called the False Claims Act. And the False Claims Act is a knowledge-based act, which at three aspects. One, admitted claims that were false. Two, you acted in reckless disregard, which is gross negligence. Or three, you acted with deliberate ignorance, which is burying your head in the sand like an ostrich. So what I would say here is, listen, before you run the risk of doing something really damaging to your professional and personal reputation, to your organization as a whole, get with a healthcare centered attorney. Get with a Gabriel Imperato. Get with an Amanda Wesh or a Gina Singleton or a Robert Lyles or a Ronald Chapman or an Elizabeth McCullough. These are the people that have dedicated their legal career to healthcare, and they can help guide you through what sometimes are very murky waters. But again, to Ginger's point, I'm going to throw it to the ladies. Can I tell you how much I enjoyed just being with the ladies today? This is so much. But as Ginger says here, blindly uniformed about policy language, about all the great resources you're currently quoting, clients often push back, right? And they push back because you're not giving them that yes answer.
Yeah.
I love to tell my clients yes, but only can stand my ground with a payer in the event that payer says, we're taking it all back, buddy boy. All right.
Well, Sean,
Christine,
here's a good
Terry,
one.
go ahead.
Yeah, here's a good one. So, first time I've ever heard this one. I think you all will be amused at this. I know my head spun around. So, I had a physician call me. He goes, so I have some patients that they're being seen by a oncologist, and I said, okay. He's like, well, sort of. The oncologist, after they found and they're diagnosed with cancer, et cetera, he goes, they have an AI bot that calls the patient for 15 minutes and gives them information on how their cancer is going to be treated, telling them all the information about it. It's not the physician, but it is an AI created image of the physician, and they can either do it and also the voice, either through audio only or through the audio and video. And then they said at the end, there's a disclaimer that says, this is not for response back, but you can go to your portal and ask questions and you'll be responded to. They're charging either for a phone call or an audio and video visit, office visit for this, and they're charging for the portal visit. Okay, so at that moment I thought, retirement needs to just come tomorrow. I thought, what is this really where we're at with healthcare? But I can't even. I just thought, how can somebody do that and think that it's okay to bill for that as an actual physician service? I mean, it reminds me of a fraud audit I did years ago. And how long it was ago was when before Medicare was CMS, it was HCFA. And they had me do this audit on a practice that would see a patient for their orthopedic problem, and then they'd go sit them in a room with a video of what their surgery was going to look like, which to me is scary. The patient's in a room with a closed door with a video going, shoot, this is what I'm going to deal with. And then they would try to charge prolonged service or charge the higher level service, adding that time. So when I'm seeing, and back then that was considered advanced technology. It was a VHS tape. See, I'm old. And so then coming forward now with AI and seeing that they're creating a doctor's image and the voice and trying to bill for this as real. I mean, Sean, doesn't that, I don't know who wants to comment on that, but I needed a minute when the doctor told me that. And I said, how do you know this is happening? He goes, because the patients came to me just so upset that they tried to respond to this call, and it kept saying, this is not an auto response. You can do it through your portal, and they had to disclose that it was AI. That was one thing they had to do. And then they started seeing the EOBs where they were getting charged for an office visit or a phone call and then getting charged for a portal visit.
Do
So
Medicare beneficiaries know what AI is?
no,
Would it not be deceiving that they see their doctor giving them specific information about their condition? It would be very easy for any Medicare beneficiary to believe that that was truly their doctor.
because it's an image in their voice and in them. I mean, we've all done the virtual reality with the goggles and everything, and it's crazy. It's fun, but it's not supposed to be that blatantly in incorrect in healthcare. I know technology advances are getting there, but this to me was just beyond what's appropriate. And to charge for it as if it was real and it was really a physician. And the thing is, I don't know. So here's the problem, I guess, where I was going with that is that the doctor's excuse for doing it, saying, well, there's no published guidance saying I couldn't do it. And I'm going to put myself on mute now. You guys can talk about that one.
I get that a lot too, Terry. There's nothing out there that says I can't do this.
I know.
But I mean, again, think about your patient load. Like I remember when my mother called me post COVID and said, my doctor had a video visit with me because I'm his favorite patient. And how disappointed she was 6 weeks later when she got a bill. She truly thought that she was super special. So I don't believe for a second that all of our Medicare enrollees understand the AI. I believe that that this is it's a ruse that we're doing, and we're billing them on top of it. How horrible is that?
Well, and I think that a lot of we've been really kind of hammering on practices that you have to be licensed in the state you're in, where the patient's in, and all this. And I'm starting to see the flip side of that, where the doctors are in some drive-through somewhere, on their phone with the patients, not HIPAA protected, or they're on vacation, or they're out of country, or I mean, it's like we're getting it from the other end. The patient's where they need to be, but the doctor isn't. And so,
sorry.
Go ahead.
There's just one thing, like, so I know that all of us, we get pushback from provider offices where they say, I can't afford compliance. I can't afford a consultant. And I think there are so many services that you are doing correctly that you may not be billing for. But instead of investing into doing the right thing, you're out there pulling things out of thin air to try to generate additional income that are not compliant, that are deceiving, and that are fraudulent. Instead of hiring someone to help you capture that revenue that you are already entitled to, that you're already doing, you just don't know. It boggles me.
Yeah, I want to say one thing about this. When I hear providers say, I can't afford compliance, you can't afford not to be compliant. Are you out of your mind? We live in a new era of over-aggressive audits and investigations and overzealous prosecutions. The fact is, you have to be able to demonstrate a culture of compliance, because under the DOJ evaluation of corporate compliance programs issued by the criminal division, there are 3 key questions that they ask. And the very first one is basically, do you have a bona fide compliance program? And does it work in practice? Is it reasonably resourced? Does it work? I mean, folks, as somebody who spends the majority of my time working with law firms around the country, both in a consulting and testifying role in civil and criminal federal cases, I will tell you, the cost of not having a compliance program far exceeds and outweighs and outcosts not having one. I think it's absolutely irresponsible for any provider. And let me just say one last thing, and then Stephanie, I want to send it over to you for some comments on using clinical staff to do a physician's job. But I want to say this. you cannot make compliance a punchline. It's got to be the tagline. Period. All right, Stephanie, go ahead.
Yeah, so I wanted to piggyback on what Christine was saying. And, I've heard over this year all of these different practices looking for additional ways to bring revenue in. And they're looking at other staff that do not have the same licenses that we're used to seeing, for example. Also utilizing MAs, nurses to provide services that really are supposed to be performed by a physician or qualified healthcare professional, which that would be our NPs, PAs for most of the time. One of the things that I found very alarming that I started to hear beginning of this year was surrounding weight loss education services. So not diving in, like Terry was saying, straight into medication. This is just weight loss counseling. And one of the things I found interesting, I heard from, I believe one of them was a neurologist, and another one was an orthopedic surgery practice. They wanted to implement this before they would pursue surgery. And this is more so with orthopedics. The plan they had in place that they were telling me was to start weight loss counseling, and all of these sessions that we would see with bariatric surgery. They wanted to do this before they would operate on patients who have comorbidities. So to them, I think there's an argument there, with the joints and the outcome of surgery being better. But to implement this for every single patient before you'll move forward with an elective surgery. And then on top of it, as you start to dig into some of the policies that exist for this, I haven't looked in a while, but I remember there being some limitations on not just diagnoses, but also the specialty of the provider. So here they think this is the answer to all of the financial issues coming up. And, it's just going to bring a lot of issues. And I just had a client say last week, I know this is an ongoing problem, a real financial problem. Just last week, I had a client reach out and say, hey, our vendors are starting to up their prices, stating it's a cost of living increase. And now they're looking at maybe renegotiating contracts they have in place or looking at other services they can offer. But most of the time, if you're going to offer that, it's still going to come on the back of your physician or your APPs, and there's not a way to get around that.
I wanted to say one thing, and I put this up because Lady Diane Martinez, said, the physician who indicated they were a sole proprietor said they didn't have to have a compliance plan. If you go over to LinkedIn where all the comments are being posted, I just put something in there that comes from the Office of Inspector General's website, and I actually gave you the citation to it. And it says, with the passage of the Patient Protection and Affordable Care Act of 2010, physicians who treat Medicare and Medicaid beneficiaries will be required to establish a compliance program. It doesn't say you should. It doesn't say you may. It doesn't say you can consider. It says, hey, ding dong, you're required to do this if you are going to treat Medicare and Medicaid beneficiaries. Folks, compliance is not an option. It is mandated under the Patient Protection Act. Listen, I've had people walk up to me at conferences and they're like, hey, isn't it true that the only required compliance programs is HIPAA or OSHA or CLIA? And I'm like, well, first, it's HIPAA with 2 A's. And second, no, that's not correct. OIG compliance is required. And I have a lot of people that say to me, well, why don't you ever see any fines or penalties about it? And in these criminal cases or civil cases, why don't you ever hear anything about it? Here's the plain fact and reason why. And pardon me for my English on this one. Because our government sucks at monitoring compliance. They do. And you can go all the way back to 2010 when it first became mandated. You can go back before that. All of the secretaries of Health and Human Services, whether it's under a Republican administration or a Democrat administration, I don't care. They all sucked. And that's the reason why enforcement's not been there. But I will promise you, if you are investigated by an agency like the Office of Inspector General, they will automatically assess civil monetary penalty damages, CMPLs, which is civil monetary penalty laws. They will start at double damages, and they will go as high as treble damages, 3 times the amount. Folks, don't play with this stuff. It is, to whoever said it before, one of the ladies said it, it's not a matter of if, it's a matter of when. All right.
Well,
Okay.
Go
Betty
ahead.
Hope posts every Friday her Friday fraudsters. And I think that sometimes we need to remember that people don't air out their dirty laundry. I have never in my career heard of a provider calling the local news to say, hi, I'm on a CIA because I got in trouble and I have all these penalties. Can you do an expo on me, please? So, I mean, I've even shared, we can do our own digging, and you can go to the OIG website. Everyone that's on a CIA, a corporate integrity agreement, or has been on a corporate integrity agreement, they're there. They're your neighbors. You can see within your particular town. You can go to the Department of Justice. You can look at their website for your district and who has been deemed a bad actor. If you really wanted to, it's out there for you to see. It's just not something everybody airs out.
Well, and there's one new one now that I was like, oh shoot. So when we started the whole PhD education, and I'm beating a dead horse, I realize, with telehealth, one of the things that was buried in some of the regulation and the FAQ sheets for fee for service for Medicare was that you have to have access for disabled patients. So if you have hard of hearing patients, deaf patients, blind patients, patients who have physical challenges, you have to make sure that your telehealth platforms also accommodate them, because you can't deny access. That's a problem with the Disabilities Act and the Office of Civil Rights. They're like, you're violating their rights. Well, I just saw 2 audits, and these 2 offices panicked, and I said, well, did you take my 2020 class? 2021, I had 27 classes on this, 2022, 30. And they're like, I think we took one, but I don't remember this one. Oh my gosh. And so I showed them the regulation. I showed that it keeps getting updated. And basically, OCR came in and sent them a letter because they weren't able to accommodate a deaf patient with the certain type of visuals they needed. And the other one is they weren't allowed to accommodate a patient who had a speech impediment as far as audio and video. And so they're taking all the money back. They didn't have it in place at the time that they started doing telehealth. So they're looking, one was looking at $192,000 in this certain time frame. The other one was looking at 2.6 million. And so I was just like, wow. Again, the government, they always tag Medicare services when, and I know now that the commercial plans are doing it too, when they want to see how they can recoup money. And, how many times do we read these reports saying, oh, Medicare found that actually this many billions of dollars was wasted or paid out, and, they're going to claw it back. Like Sean said, if you don't have certain things in place, and don't do things, I hate to say it this way, but half-assed. Don't do it just to do it. You have to make sure that you have workflows in place. Like Sean said, required compliance policies and a plan. Everyone signs off on it, knows what that is. And I still have offices and clients, whether it be single practitioners, or one of my biggest clients has 175 physicians in their organization. And I say, can I take a look at your current compliance plan? I'm looking for something. And they're like, okay, let me see if I can find it. First thing they always say, and then they don't know where it is. And then when they find it, I notice that it's date stamped like 1995, and I'm like, wow, that's when my daughter was born 28 years ago. And so nothing's updated. And how can you not update? Remember, okay, for all the whole panel, remember when, and we've all been doing this collectively like over 100 years. So remember when Medicare used to update us every 6 months, and then they went to every quarter, and then they went to every month, and that's every day. How can you not update something? Because there's all kinds of published guidance that comes out every day. Go ahead, Sean.
Well,
Sorry.
To wrap that point up, I love when clients say to me, well, Sean, I have a compliance plan. I'm like, okay, great. Let me take a look at it. And I look at it, and you can tell it's a complete template. They went online, they either downloaded it from, someplace, that, just
Templates are us.
published their own online, or, they bought it for $99 in a box. And, when they do that, they're like, well, we're fine. We're protected. And I always use a line from one of my favorite movies. It's A Few Good Men. And the line goes something like this: does Aunt Ginny have a barn? We could hold the trial there. Maybe I could sew the costumes. Maybe Uncle Goober could be the judge. I mean, come on. If you're going to have a compliance program, have a bona fide compliance program. Don't buy one of these garbage things in a box. Yeah, Acme template. It's like the Wile E. Coyote and the Roadrunner, right? I mean, come on. I know we're adding a little bit of humor from this, but folks, I mean, just be smart about this. To Alonda Sylvester,
I
the
don't see it
OIG
either, Sean.
information you're looking for is in the comments.
I didn't see it either, Sean. I
you'll-
just went to look for it. It didn't post.
Oh, it didn't?
No,
Well,
you have to
let's see if
repost
it
it.
does it right here. Hold on. I'll put it right here for y'all. Give me 1 second. Let's see if this posts. All right. Let's see if you get it right there. All right. So let me throw it to Stephanie. It's amazing how efficient we are without Paul and Scott. So let me throw it to you, Stephanie, first for some closing thoughts on our podcast today.
Yeah, so I've said it before. I think we'll continue to say it in the future, but nothing can be done without the base research. It's not something that you're just assuming because you've heard it. There's a lot of times that I'll talk with practices that have been in place for 20 years and they haven't changed in the 20 years. So just like Terry was saying now, you need to check the pulse with regular audits to see those basic services that you're comfortable with, where you're at with that. And then any new service coming out. One, Christine or Terry, you mentioned today, doing your research when you want to start a new service. There's so many times where I have practices who start to bill a new to them CPT code that's time-based, and they don't think time is required. So, we have to make sure we're doing the due diligence, getting the word out there, checking everything before you just jump in. And you don't have to be a coder. You don't have to be an auditor to figure this stuff out. You can reach out to the different resources out there. You can reach out to our different organizations to ask for help. But in some way, you have to be checking this because there's no getting out of an explanation or an excuse when you're found to have done that in the wrong way.
I think you hit it on the head, Stephanie.
Excellent.
You
All
can't
right.
say we've always done it this way. Change is the only constant in our industry. So that statement is so antiquated. We should never ever repeat. This is how we've always done it. Also, another statement: will we get paid for it? That doesn't necessarily mean that you've been paid appropriately for it, or that it was medically necessary for the payer to pay for that. There may have been some other way. So engaging people to help you with your compliance program. And it's not just the manual. It's not just the meetings. It is not just the audits and education. It is all those things combined that make a program. It's a living, breathing part of your entity there. So I say again, you've got to reach out. You've got to reach out for some help. Make sure that you're doing it right. And that's the last thing. How do you know you're doing it right? If you don't have audits, if you're not monitoring, if you've never had someone externally come in with no bias, or you've got internal, auditors that are doing your auditing, how do you know you're doing the right thing?
And then I'll just kind of end with my segment here. In just echoing a lot of what the lady said and also what Sean said. One of the things that's part of our job, not just as an independent consultant myself, I know Christine too, and I know Sean and Stephanie working with Doctors Management and NAMIS. We all have memberships. They're all paid memberships. Please don't abuse and come to us and expect free information. We do our due diligence. We do these podcasts to give you insight on what you need. But if you need us to go a step further and give you that published guidance, research it for you, we're happy to do that. But it is part of what we do as far as our businesses. So expect that. We'll ask you to join our membership services to get that. Or to engage us. Because the thing is if you use our information and you haven't engaged us, then we're all on the hook for something that we don't have a BAA, we don't have, any way to kind of recourse to say, this is how we found our information. So I just want to put that out there. But also remember too, especially with some of the new things that are coming up for 2024 on the final rule proposed, oh my gosh, especially in the behavioral health sense. I saw that they're going to allow payment. And to me, there's one pie, and that pie is getting shrunk every day for behavioral health coaches and for, family counseling. And there's very little oversight on this. And also there's very little guidance on how credentialed those people have to be. And so I had a couple of physicians and a couple of nurse practitioners and PAs already. I'm surprised I haven't had an acupuncturist come to me and say, can I do that? I mean, basically they're just like, so we could do this, right? We don't have to have any kind of mental health certification or any kind of behavioral health background. I'm like, well, if you look at not just this published guidance, but then you have to go through 3 different things. Again, that's what we do. It kind of says on page 14 of this 300-page document, by the way, you have to have a credential or, a licensure in the public health or in the behavioral health or mental health space. So sometimes it's hard to find, but this is kind of what we're all talking about here. It doesn't mean that you can say ignorance is bliss. I couldn't find it, so I'm just going to do it anyway. And then we'll send it back to Beanie Ann over there. I don't know what he's doing.
All right. So great panel discussion. Thank you for all of the comments from our listeners, viewers, our followers. We greatly appreciate you. Once again, I have on the Mason merchandise. It goes to a wonderful cause, the Tafida Rakib Foundation. I posted the link to the Mason merchandise earlier in the podcast. I'm not joking when I tell you this is probably some of the most comfortable sweatsuit stuff you could wear. The pants, the sweatshirt, the beanie. All right. So on behalf of Stephanie Howard, Terry Fletcher, Christine Hall, Aunt Jenny in her barn, and Uncle Goober, who's serving as our judge, thank y'all for hanging out with us today. Thanks for tuning in, logging on, and being a part of this program. Terry and I will be back tomorrow with our hashtag Terry Tuesday. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.